Welcome back. So before the statins came along, we actually treated primarily lowering blood cholesterol levels by using the bile acid sequestrants. These are cholesterol lowering drugs. They are called bile acid binding resins or ion exchange resins, and the most common being Questran. You'll also hear of cont'd and Welchol. The way that they work is that you have to have bile acid for the absorption of cholesterol. So it prevents the resorption of the bile acid from the small intestine, therefore preventing the absorption of the cholesterol. They are not absorbed systemically, and they are used to treat type 2 hyperlipoproteinemia. They can also be used with along with statins if we don't have a significant reduction or need more power behind the reductions. We also will see them used to relieve the pruritus that's associated with the partial biliary obstruction. Now, because they're not absorbed systemically and the action is only in the GI tract, all of our adverse effects are in the GI tract. You'll see constipation, heartburn, nausea, belching, and bloating. These adverse effects tend to disappear over time, but the patient may find them intolerable. These are good drugs in a patient who cannot take the statins for some other reason as well. Then we have niacin, our B3 niacin. It's our vitamin B3. It has low lipid-lowering properties, but our lipid-lowering properties of this vitamin require much higher doses. So if we're taking it as a vitamin, you're probably taking about 25 milligrams a day. As a lipid-lowering agent, you'll see 2 gram to 3 gram a day doses. It's effective, it's inexpensive, it's often used in combination with other lipid-lowering drugs, and it's available without a prescription. So because it is, you will sometimes have patients that will try to self-medicate with this drug. One form of the niacin that's available over the counter as a vitamin supplement is called nicotinamide, and it has no lipid-lowering effects. So we need to be sure that patients are informed that if they're using lipid-lowering niacin, that it needs to be under the direction and supervision of a provider. Niacin, we think, works by increasing the activity of lipase, which breaks down the lipids, and it reduces effectively then the metabolism or the catabolism of cholesterol and triglycerides. It's indicated in lowering triglycerides, total serum cholesterol, and LDL levels. It increases HDL, and so it's effective in the treatments of type 2A, 2B, 3, 4, and 5 hyperlipidemias. So pretty effective, pretty efficient. However, almost everyone who takes niacin for lipid lowering experiences niacin flushing. It's caused by the histamine release. And these flushing and hot flashes occur, like I said, in almost every patient. Now, taking one aspirin 30 minutes prior to the niacin administration can reduce the flushing. However, now we've added another medication. So I have to be sure that this is a patient who can actually take that aspirin and isn't going to have interactions with other medications that they might be taking or contraindicated for some reason. Other adverse effects include pruritus or GI distress. We can see it, as I said, used in combination with statin or the bile acid binding drugs. And so they could be additive effect. And because of that, there are a couple of fixed dosed combination drugs available, like Advicor, which is niacin and lovastatin, or Simcor, which is niacin and simvastatin. There's also an extended release niacin, which is taken once daily, and that form of the drug causes less flushing and less GI adverse effects. So that takes us to our fibric acid derivatives. These are known as the fibrates. They're gamfimbrazole or Lopid or fenofibrate, brand named Tricor. And these drugs are used to lower triglyceride levels. They actually have very little effect on the LDLs. It was once these were commonly used to reduce the lipid levels, but they've largely been replaced by the statins for most indications. Sometimes they will be used in combination with a statin, but this has reduced greatly unless there is great benefit, because the risk of rhabdomyolysis is exponentially higher when we have the fibric acid derivatives prescribed concurrently with any of the statins. So how do they work? Well, they work, we believe, by activating lipase, which breaks down the cholesterol, and they suppress the release of the free fatty acid from the adipose tissue, which inhibits the synthesis of triglycerides in the liver and increases the secretion of cholesterol in the bile. They're used in the treatment of types 3, 4, and 5 hyperlipidemias. The fibric acid derivatives, gimfimbrazole and fibrate, decrease the triglyceride level and increase the HDL cholesterol by as much as 25%. As I said, they have actually very little effect on the LDL. So we will see these primarily used when the phenotyping shows high triglycerides or the hypertriglyceridemia. Now, they do have adverse effects. Usually these are GI effects, abdominal discomfort, diarrhea, nausea. They may have some blurred vision or headache. There is an increased risk of gallstones with these and a prolonged prothrombin time. Liver enzymes may be elevated, so this is something that we would probably monitor in the patient. The provider is going to order that, and we would monitor that for them. They do have many interactions. They sometimes will interact with the statins, or they will increase the risk for myositis, myalgias, and rhabdomyolysis. It interacts with the oral anticoagulants, and our laboratory test will show a decreased hemoglobin level, hematocrit value, and white blood cell count. So we've got this broad problem with the indices of our CBC, as well as an increased activated clotting time, and increased lactate dehydrogenase level, and an increased bilirubin level. So when we think about the liver, that's where that bilirubin and that lactate dehydrogenase level increases are occurring, as well as the increase in the activated clotting time. Our cholesterol absorption inhibitor is Zetia. It inhibits the absorption of the cholesterol and the related sterols from the small intestine. So what happens is we have a reduction in the total cholesterol, the LDL, and the triglyceride levels. It also increases our HDL, and it's used frequently in combination with a statin drug. Some of our other newer agents are mipirmericin. This is a once-weekly subcutaneous injection. Our microsomal triglyceride transfer protein inhibitor, or lamiptide or Juxtapid, and our proprotein convertase subtilis kexin 9, or the PCSK9 inhibitors. This is alirocumab and evolocumab. So those are some of our newer agents. Let's talk for a minute about some of our herbals, or some of our CAM therapies. The herbal product garlic is used as an antispasmodic, an antihypertensive, an antiplatelet, and a lipid reducer. Adverse effects for garlic include dermatitis, vomiting, diarrhea, flatulence, and antiplatelet activity. Can also have interactions with warfarin and diazepam, and it will enhance bleeding when it's taken with NSAIDs. Herbal flax, or herbal product flax, it comes in both a seed and an oil. Sometimes that will be used. It's used for atherosclerosis, hypercholesterolemia, GI distress, and menopausal symptoms. It can cause diarrhea and allergic reactions. When we see this interact, it's usually with our anti-diabetic drugs and our anticoagulant drugs. Another one that you'll see used is our omega-3 fatty acids, or fish oil. The fish oil capsules can be used to reduce cholesterol. Frequently, you'll hear patients don't like it because they belch, it tastes like fish. It can cause a rash and allergic reactions. There's also, again, potential interactions with anticoagulant drugs. And although I don't have a slide for it, there's also the CAM therapy, red yeast rice. And so red yeast rice is a supplement that's produced when rice is fermented with the yeast Moniscus purpuris, and it's sometimes reduced to a powder and used as a coloring or a flavoring. It's been used for centuries in Chinese medicine to treat various digestive disorders and liver disorders, but more recently it's been used to manage high blood cholesterol. It's clearly effective at lowering cholesterol levels, and this is likely because it contains a chemical that's actually identical to the prescription drug lovastatin. Surprise, surprise. So in 2007, the Food and Drug Administration decided that red rice yeast should be regulated as a prescription drug. Some supplement manufacturers remarketed the product after removing lovastatin from the red rice yeast. So to avoid legal action, most red yeast labels do not mention a cholesterol lowering effect. And it's unclear whether the lovastatin removed, per se, product has any ability to lower blood cholesterol. So if a patient is trying that, they need to be sure that they're discussing that with their healthcare provider. So let's talk quickly about some nursing implications. Before beginning therapy, we want to obtain a thorough health and medication history. We want to assess the dietary patterns, exercise level, weight, height, vital signs, tobacco, alcohol use, and family history of cholesterol problems. Assess for any contraindications or conditions that require cautious use of these drugs or any drug interaction potentials that would be there. Contraindications would include biliary obstruction, liver dysfunction, and active liver disease. We want to obtain baseline liver function studies. Patients that are on long-term therapy are going to need supplemental fat-soluble vitamins because remember, those are going to be affected by this treatment. We want to refer to guidelines for each of these on administration times and meals. When we counsel our patients, we want to counsel them concerning diet and nutrition on an ongoing basis. And so they need to increase their physical activity. That raises the HDL and lowers the triglycerides. We want their diet to help them maintain a weight that's within a normal range. If they're going to implement any extreme diet or extreme exercise plan, they need to make sure that they're checking with their provider first. Their cholesterol intake itself through food should be lowered. So we want to teach them how to do that. Instruct them on the proper procedure for taking their medications. Powder forms must be taken with a liquid, mixed thoroughly but not stirred, and never taken dry. I know it sounds crazy, but I don't know how many times patients have tried to take that packet of Sequestrants dry. Other medications sometimes should be taken an hour before or 4 to 6 hours after a meal. So we want to make sure that we're teaching the patients the right things and writing that down for them. To minimize those effects of the niacin, they can do a low dose, start on a lower dose and gradually increase it. Take it with meals. And remember, small doses of aspirin or NSAIDs could be taken to minimize the flush. But we want to provide the teaching regarding the use of NSAIDs and aspirin and make sure that they don't have interactions or potential for problems. Inform the patients that these drugs can take several weeks to show effectiveness. Instruct them to report any persistent GI upset, constipation, any of these problems, yellow discoloration, jaundice, because we're monitoring for liver enzymes, monitoring for the therapeutic effects of these drugs, which ultimately we want to see a reduced cholesterol and triglyceride level. We want to see a high density lipoprotein high and low density lipoprotein low and triglycerides low. If you have questions, you know how to get a hold of me, email, text, call, or post it in the discussion forum. I'll look forward to seeing you soon.